Morning, Marty.
Good morning. How are you?
I'm good. Good. Down in Florida for a couple of months, so I'm enjoying. Show you the view if you like.
You know, that looks like Wisconsin. I see lots of.
You know, Nick, you're drifting quickly to "we're happy for you" to "we hate you." So pictures like that.
Okay, I'll be quiet now.
Just kidding. I'm really happy for you.
I was on a Zoom call with somebody in Wisconsin yesterday, and they opened the blinds behind them, and it was absolutely nothing but white trees, white ground, everything. And I'm, what the first 50 winters of my life were great, but now I'm glad to get out of them for a little bit. Good to see you.
You can take it away.
Okay. Good morning, everyone. Thanks for joining us from near and far. Today we have Christina Hoppe, who's a second-year oncology pharmacy resident presenting today. She's going to be discussing SNRIs and pain management. And the format's going to be a PowerPoint with discussion throughout. I always recommend, especially when there's discussion within the PowerPoint, use the chat. And Christina, if you can't see the chat, no problem, I can, so we can manage it that way. Or feel free to put your camera on and talk with us. So Christina, over to you.
Thank you, Rose. So before we dive in, I would first like to maybe open up this discussion part and hear from anyone if you've used SNRIs or selective norepinephrine reuptake inhibitors as part of pain management. And if so, if you wouldn't mind sharing successes of that or failures. So if you've used them, please let me know.
I have used them. I will tell you, and maybe your talk will enlighten that. I don't have any experience with saying, here's a primarily pain management problem. My go-to is SNRIs. There's a, if you will, a more holistic, given whatever else may be going on with the patient, then SNRIs may come in there as part of pain management, but I'll stop there.
I must say that even though my go-to is to reach for the gabapentinoids, I know that the literature shows that the number needed to treat for most of the TCAs and the SNRIs is, I think, far superior. So it's interesting that I think my go-to drug ends up being something that does not have as much efficacy in the actual literature in the database.
So I have used Duloxetine mainly when I'm seeing patients with neuropathic pain in cancer, and have used it very frequently.
Thank you, everyone, for sharing. So as we start this discussion, I did want to present a little bit of background of norepinephrine and a little bit of its sensory in the neurologic pathways. So the locus coeruleus is the largest bundle of neurons that store norepinephrine, and it's housed near the brainstem. And stress-related disorders modulate the locus coeruleus, such as depression, anxiety, and pain, especially the inflammatory pains. The ascending norepinephrine pathway, there's a sense in the peripheral pain pathway. So the signal goes into the spinal column and heads up, and that's what we get our pain sensation. It's also related to the emotional pain aspect. So an example of this is, what a shame it hurts so much. And then it's also related to the cognitive aspect. So an example would be that when we're little, we learn that a sunburn is supposed to be painful. Some of us who may have had a sunburn in the past probably know that not all sunburns are the same, but we think that they all should be equally as painful. And then norepinephrine works in the descending pathway to suppress this pain transmission. However, with hyperexcitability, we get less suppression over time. And so that leads to those chronic pain those chronic pain conditions that we're not able to endogenously suppress as much. So SNRIs are selective serotonin and norepinephrine reuptake inhibitors, block the reuptake of serotonin and norepinephrine from the synapse. So that leaves us with more serotonin and norepinephrine to help dampen that pain expression. The analgesic effects of these SNRIs is independent of the antidepressant effect. So sometimes we'll see this analgesia effect at lower doses than we would need to see for the antidepressant effect. There is a faster onset of analgesia than the antidepressant effect. We know for their antidepressant uses, we probably need at least a month or two to see some effect of that. We do see the effect of the analgesia probably within a week. But again, as these are longer duration products, it can take up to 8 to 14 weeks to determine the appropriate dose needed for that patient. So most of the indications for the pain management, they're non-acute pain conditions. So it's musculoskeletal pain, low back pain, fibromyalgia, neuropathic pain. And in some cases, we can use more specifically the gabapentinoids for postoperative pain management. As far as opioid use in combination, some of the treatment modalities and who recommend using opioids in third line or in combination, and that's more specifically for the neuropathic pain, whereas these modalities we can use earlier on. However, they can be used in combination with the opioids. So I was wondering if anyone, I think we kind of touched on it a few minutes ago, use them in combination with opioids. So I was just wondering if I could ask the audience what their experience seems to be when using them in combination with opioids.
This is Sandy Moshka. Yeah, I've done both. Usually it is in combination with an opioid. I don't think I really have just used like the duloxetines and things like that on their own. So it's usually, because mostly I see cancer pain. So that's usually why we're using both. It's usually a multifactorial type etiology. So.
As far as evidence, so duloxetine we can use for osteoarthritis, and there's been phase 3 randomized trials, however open label, to show that there has been improvement in pain management and quality of life. For neuropathic pain, especially in diabetes and cancer-induced neuropathies, it's demonstrated effective pain relief. And a double-blind placebo-controlled trial assessing the neuropathic pain management refractory to gabapentinoids and opioids found the addition of duloxetine can provide benefits, and the dose was less than that, but the dose in that trial was less than the 60 milligrams per day that's recommended for the analgesia. And then it can be used in chronic low back pain and fibromyalgia, as well as postoperative pain. For chronic low back pain, it did show that about 91% of duloxetine's effect came through the direct analgesia, whereas 9% came from its antidepressant effect. So again, with it being a selective norepinephrine and serotonin reuptake inhibitor, it's working in that pain modality where a lot of times depression can be linked with chronic pain. And the study did show that the antidepressant effect did help in the management of the chronic back pain.
Christina, could you, I'm sorry, I'm trying to take notes. Thank you so far, but say again about dosing for analgesia versus depression, and what would be for any of these indications where you would start? Would you for dosage?
So I found for duloxetine that it's recommended 60 milligrams a day for the pain, and you should probably titrate starting at 20 milligrams and then slowly titrate up to the 60. With the antidepressant, I've seen it used up to 120 milligrams a day, so that it can be some hefty doses, but the recommended dose for the pain is 60 milligrams per day.
Thank you.
Mhm.
And Christina, does that come from, I think there's some literature out there that talks about that there's really not much benefit for pain control beyond 60?
Yeah, that's kind of what I found from the literature as well.
This is Rachel. I've had quite a few patients, especially with fibromyalgia, who have responded very well to duloxetine or Cymbalta alone in the past, anecdotally, of course, but.
Christina, you may get to this, but I work with a lot of heart failure patients. And so my cardiologists are always very concerned about QT prolongation. You know, obviously we start anything we start, we're going to get an EKG at the beginning. One of those things that's always a sticking point with any SNRI or SSRI that I look to use. So.
Okay, sorry. Okay. So the next one that next NRI is Milnacipran. Its only FDA indication for use is for fibromyalgia, and it's dosed at 50 milligrams per day. I do have the taper up for that one listed here. And then this one, it's also really important that if we do stop this or any of the SNRIs, that we taper off and not abruptly discontinue. So a Cochrane review of the fibromyalgia showed moderate pain relief, as well as increased incidence of ADRs with the use of Milnacipran. And it does have, if a person does have a history of serotonin syndrome or a neuroepileptic malignant syndrome, or uncontrolled hypertension, or a history of seizures, then we probably shouldn't use Milnacipran. So I would say out of all the SNRIs, this one probably not a go-to or a workhorse. I would say Duloxetine is more of that one. And then Venlafaxine is commonly used for neuropathic pains. And then a systematic review did show improved reductions in the neuropathic pain compared to placebo, but when compared to gabapentin, carbamazepine, and duloxetine, it was non-inferior. And then a study did show that it may reduce chemotherapy-induced neuropathic pain, but that study was limited due to its small sample size and short duration of treatment. So again, starting dose is low and goes low to 75 milligrams daily. So this one we can go till we see an effect. Maximum dose is 225 milligrams daily, which is what sometimes we see for antidepressant.
So this is an unfair question, but I'm going to ask it anyway. You said it was inferior to duloxetine. So is that just a marketing thing that, Cymbalta got out there and said, hey, this works for neuropathic pain, but it's, from what you said, Christina, it's pretty much equivalent if you got the right dosages? Does that make sense?
Yes. So I think I am understanding the question. Duloxetine probably just has a lot more literature and support to use for use rather than Venlafaxine's a newer one, looking into these pain modalities.
Sure. Thanks.
So some side effects of the SNRIs is nausea, dry mouth, insomnia, constipation, fatigue, hypertension, selective serotonin syndrome, and discontinuation syndrome. So serotonin syndrome, important to watch out for that jitteriness, sweating, hypertension, fast heart rate. So, and it can happen, especially when we're using these in combination with other palliative medications. So I know quetiapine is a good medication, but it does have an interaction. So really important when we use these to make sure that we minimize the drug interactions with other serotonergic agents. And then again, discontinuation syndrome, really important to slowly taper our patients off of these. And then of note, I do want to make sure that everyone's aware, if a patient has depression or suicidal ideation, it does not preclude them from use. Just really important to, when we do use these medications, because it does have that immediate excessive depression before we have the antidepressant effect, like we would use them. So we really want to make sure that we keep an eye on those patients.
There's a question, Christina, in the chat. Is there a rationale for dosing SNRIs BID? I regularly see patients who were started on such regimen as an outpatient, especially Duloxetine.
I don't know if this is right. I know some of the literature on some of the other medications, for example, dexamethasone. Even though dexamethasone has a half-life that's long enough that once-a-day dosing is more than sufficient, there's some small literature out there that suggests that if you dose it BID, there might be a slight reduction in the amount of side effects. I think it's subtle, so perhaps that rule applies. I don't want to say it does, I just don't know, but maybe that's where that comes from other medications extrapolating that side effect profile might be less with BID dosing.
Oh, and then Rachel had commented, when I was in pain management, had a few patients who told me that if they took 60 milligrams Cymbalta at once, they didn't get as good of pain relief versus twice daily. To clarify, 30 milligrams twice daily, same as full dose. So maybe it is a half-life issue.
Maybe.
Yeah, I really appreciate this because I think it's something that we should be open to, but sometimes comfort level, or, you know, when you're utilizing opioids as well, you know, I think hearing more about these things and the various uses is good information.
Talked about using duloxetine and opioids, but what about the duloxetine and gabapentins? Is there a preference? I know this wasn't really the crux for your talk, but of starting gabapentin first or duloxetine first, or is doing them both together? Any thoughts about that?
The best, I think, when I'm thinking about that question, which neuropathic agent am I going to start? I think it really all boils down to perhaps two different things. It's what is the side effect profile, or what's the risk? And then how effective is it really? And I know that for the main triad of neuropathic agents, the TCAs, the SNRIs, the gabapentinoids, their efficacious is different. And if you really simplify it, the TCAs have a number needed to treat somewhere around 3. It varies from study to study and indication. And the SNRIs have a number needed to treat roughly around 5, roughly. And the gabapentinoids have a number needed to treat somewhere closer to 7. And so you would think that we would start with the TCAs and the SNRIs first, but then when you think about the other question, what are the risks and the side effect profiles, that really, I think, draws a lot of people to the gabapentinoids because there's many fewer drug-drug interactions. And the risks that are there theoretically are less serious.
Yeah, that makes sense, Marty. Thanks.
Yeah, that really is a good point. And I think, you know, when you look at each individual patient, that's where you're going to make that decision, right? I think another thing that I think about is this a patient who maybe they're depressed, maybe they're on an antidepressant, but maybe we're seeing some polypharmacy and we want to kind of back off on some things. You know, would the SNRIs be helpful in that situation? So, I mean, I think there's a lot of good considerations depending on the patient.
Hitting two birds with one stone. Yeah, hitting their depression and their, yeah.
Yeah, I agree, Rose. I think that's usually the rationale, right? So duloxetine is basically, I prefer it when we have a patient with cancer and they have a history of chronic pain, have depression. You know, duloxetine is a very good choice because we know that is going to be basically helping three things, right? Gabapentin, as Marty said, that, you know, there is less drug-drug interactions. Sometimes we would start it, but if we reach to a point where we are reaching the maximum dose for gabapentin and we are not able to titrate it higher due to, you know, maybe renal failure, that's when we would sometime add duloxetine too to see if we can get more adjunct effect. And I have used gabapentin and duloxetine both together at times, and I have seen good results too. So yeah, it's case by case depending on how you can treat multiple symptoms from the medication.
Any other comments or questions? This was really a useful presentation, Christina. Thank you.
Yeah, you're welcome. Thank you for allowing me this opportunity.
Thanks, Christina.
All right. Thank you, everybody.
Thank you.
And thank you.
Thank
Thank you very much, Christina.
Yeah, thank you.
Have a good rest of the weekend.
You too.